Welcome, and thank you all for inviting me and having me come and talk about the work that we do in Texas. I'm the manager of the Texas Primary Care Office, and all of you have a primary care office in your state. And the role of the PCO is basically to help get health professionals into the underserved shortage areas where they're needed. And if you don't know your primary care office, reach out, find out who they are, and what the snapshot looks like in your state. One of the key roles of primary care offices is to measure access to health care. So we are the office that designates health professional shortage areas for primary care, dental, and mental health services. We also designate the medically underserved areas as well. And so we're looking at the distribution of providers to population across our state. When you look at the national picture, health professional shortage areas vary from state to state. And this is one of Fqhc's maps showing where we have areas that are shortage, where we have populations that are shortage, and where we have high need health professional shortage areas. Primary care offices also work to recruit and retain physicians into those identified shortage and underserved areas. So we work with physicians, we work with dentists, and depending on the program, like the National Health Service Corps, we may also work with nurse practitioners and physician assistants and other health professionals as well. We also work to expand the safety net. Part of our work involves expanding and developing federally qualified health centers as well as rural health clinics. In Texas, we have about 300 Fqhc sites and about 300 rural health clinic sites. So one of the things that we do is answer questions about what are the requirements for becoming an Fqhc? What are the requirements? How do I become a rural health clinic? What's the difference? What's going to work best in my community? And our role is to really help clinics and organizations and hospitals understand these different programs and how a safety net works and how it can serve their community. When we look at Texas, sometimes this is how it feels, is that, we have all the problems and we have all the distances and all of the challenges that a state can have. And it's when we come to a national meeting that we realize that we're facing the same issues that other states are facing. When we look at measuring access in Texas, the health professional shortage areas tend to be across the state. And the little islands that you see are inner city, urban, underserved health professional shortage areas. So it really varies from community to community what the access looks like. For mental health, it's actually a bleaker picture. The dark colors are areas where we lack psychiatrists. And in many counties, we don't even have a psychiatrist. So working to improve the mental health picture and access to health care, this being National Mental Health Month, is one of the challenges that we face. Most of us, when we think of underserved areas or shortage areas, think of this. We think of being out in the rural frontier parts of Texas, where it may be 68 miles to the next physician or hospital. And in fact, that is the case. But we also have inner city underserved areas where, think of this woman's position, having a sick child and having to take 3 transfers and wait 2 hours to see the physician. So it's very challenging for our communities and our constituents. We have 64 counties that have no hospital, and that's about 25% of the counties in Texas. And the counties in Texas are are small. They're about 30 miles by 30 miles. And this has sort of a historical reason for development in that it was about one day's wagon ride from county seat to county seat. And that's why we have so many small counties. If you look at New Mexico, they have large rural counties. If you look at California, there are 88 counties, around that number, where we have 254. So our counties are much smaller, but they make sense on a geopolitical basis and also on a time and distance basis. We have more counties with no primary care doctor today than we had back in 1989. Part of that is because the rural population is declining and the urban population is increasing. In looking at shortage areas and designation and access, sometimes it's a question of supply or distribution. In Texas, it's both. We don't have enough providers. I think we rank 48th among 50 states in the provider to population ratio, but it's also a distribution problem in that, there are areas and communities where there aren't enough providers. And even in those areas that are losing population, they still need the providers. When we talk about recruiting tools for the underserved areas, there are a wide variety of tools. Scholarships, as a tool was saying, student loan repayments for paying for medical school and even pre-med, loan forgiveness, tax credits, J-1 visa waivers. The tax credits, I think, are fairly interesting. What we have is a number of states that are doing income tax credits. In Texas, we don't have income tax, so we don't have an income tax credit program, but you better believe we use the fact that we don't have an income tax as a recruiting incentive when we're talking to physicians from other states. The National Health Service Corps, of course, is probably the program that most of you are familiar with. The first three programs on this slide, NHSC, the military scholarship and loan repayment programs, and the state loan repayment match program are all federal programs to increase access to primary care providers in shortage areas. Behind each of the programs, I've listed the number of states that have these type of programs. So with the state loan repayment match program, which is part federal dollars and part state dollars, there are 29 states that participate in that program. And then there's states like Texas that operate their own loan repayment program with just state funds. There are a lot of reasons for that. Our state-funded loan repayment program goes beyond primary care, so we have a second priority or a second selection opportunity for some of the subspecialists that we need to participate as loan repayers. We also have a program for physicians who are not in health professional shortage areas, but are serving a high number of Medicaid patients to receive loan repayment. So that's just part of a state identifying its needs and expanding the loan repayment program to meet those needs. State loan forgiveness and scholarship programs are also common. There's a difference between loan repayment and loan forgiveness. With a loan forgiveness program, at the time the loan is taken out or applied for or received by the recipient, it has a loan forgiveness option. With loan repayment programs, that option perhaps wasn't there or didn't exist when the student took out the loan. So when we talk a lot of times with providers and communities, loan repayment and loan forgiveness are interchangeable, but they're really not. It depends a lot. In fact, it depends on the type of loan that the student took out. Again, the state tax credits, whether it's a state income tax credit or even an incentive to do a tax abatement or property tax or corporate tax to attract the physician to the community or the state, are also things that some states are using. New Mexico has an income tax credit program. And then we have foundation or university loan repayment programs. In Austin, we have St. David's Foundation, which is a nonprofit hospital that does loan repayment in partnership with the Higher Education Coordinating Board. So it's actually foundation funding that provides loan repayment, but those loan repayment opportunities don't go to the St. David's Hospital providers. They go to safety net providers in the community that work with St. David's Hospital. So it's a unique program, and it's just an interesting way to see that, other organizations are stepping up to the table. One time when I was traveling across Texas to go to a meeting, I stopped in at a convenience store, and they said, "Where are you going and what are you doing?" And we started talking about loan repayment. And the convenience store clerk said, "Oh, we have a lady in town who's pretty wealthy, and she will pay off the physicians' loans if they'll come to work at our hospital." And I thought, there's probably opportunities like that in small communities that aren't even on our radar. But I think that's another example of a type of program that might be out there. When I was asking states what they do, I found the Wyoming program to be really interesting. Instead of focusing on incentives to the providers, their incentives go to the employer so that they can provide a signing bonus, so that they can provide relocation expenses, cover $20,000 in malpractice premiums, spend $10,000 on advertising and recruiting. So altogether, the employer can tie into $80,000 or up to $80,000 for the recruiting of a physician. And you heard what it costs to recruit a physician. So I thought this was really a creative program and a good option. The J-1 visa waiver program has been an outstanding tool for Texas for recruiting physicians. Just to give you sort of a summary, foreign medical graduates come to the United States to get their residency training on a J-1 visa. And they agree to return home for 2 years in exchange for that visa. The 2-year return home requirement can be waived if a state or federal agency will request a waiver, actually recommend a waiver at the State Department, to waive the 2-year requirement if they will work for 3 years in an underserved area. And the state agencies and the federal agencies can fine-tune the program within the federal parameters so that it meets the state's need or the federal agency's need the best. So the flexibility within the Conrad 30 program is that states can do primary care only or primary care and subspecialty. They can do health professional shortage areas or health professional shortages and medically underserved areas. There's also an option within the Conrad 30 to allow 10 flex slots where the physician could work outside of a shortage area but serving a population from a shortage area. And states have the option to use those flex slots or not. In Texas, we had 42 applications for our 30 slots. So we focus more on the health professional shortage areas. We don't do flex waiver slots because We have so many needs and so many shortage areas that that's where we really want that resource to be used. All 50 states operate a Conrad 30 program, as well as the district in Puerto Rico and Guam and the Micronesias. So there are basically 54 waiver programs across the country. We've tracked data for the last 14 years in Texas to show where the states are using waivers, whether they're doing primary care or subspecialty, whether they're in urban areas or rural areas. And what we've seen is an uptick in the number of states filling all 30 waivers. Last year, 22 states filled all 30, and that's an increase over the last 3 years. It was a total of just over 1,000 waivers. When we look at incentives, whether it's J1, whether it's loan repayment or a scholarship, I always like to see these as being a barter arrangement or a three-way partnership. Everybody has to feel like what they're getting is equal to what they're putting up. So for a physician, it has to be a high enough rate of loan repayment to make it worth working in a shortage area. And then our hope is that 3 years or 4 years of work in those areas will engage them with the community. One of the stories I tell is about a community that was calling to get another J1 waiver physician. And I said, well, how's the one working out that we recommended for you? And they said, well, he married one of the local girls, so he's going to stick around. And I thought, that's probably the best retention strategy I've ever seen. So as long as everybody gets what they're expecting or what's an equal partnership to them, the three-way agreement tends to work. Sometimes it looks like this, which is a three-way switch. You have a lot of different factors. The physician may be totally happy with the practice, but the spouse may not be happy. There are a lot of different elements. We see practices, decline because the population's declining. There are a lot of things that can impact this three-way relationship, but we really, want to stay in touch with the providers and with all the parties involved. Primary care offices evaluate and look at what works well. This plan, do, study, act cycle. It's pretty typical within public health and within many arenas. But, looking at what works well is why we expanded our state loan repayment program. And that's why we do subspecialists in the Conrad 30 program, is that we looked at what was working well and we looked at what we needed. With National Health Service Corps focusing on primary care, we had a real pent-up demand for subspecialists even in our rural communities. We had hospitals that needed anesthesiologists in order to be able to do surgery. That just makes sense. So we recommended anesthesiologists through the Conrad 30 program. From training into practice, there are lots of programs. There are state-funded programs, federal, local, and foundation programs. Lots of different options, primary care or subspecialty. For the providers, we talk a lot about finding what works for them. So we go out to the residency programs and we talk about loan repayment. And we talk about, different programs and how they work. Why the state loan repayment program may be more attractive than looking at National Health Service Corps. Dollar for dollar, they're about the same, but if someone's a subspecialist, they really need to be looking at the state program. So getting a match to the program is important. The resources in your state, again, the primary care offices, and we work with our state offices of rural health if we're not co-located, but are great resources for knowing, where there are loan repayment programs, where there are different funding options. And then the constituents that are in the federally qualified health centers, the rural health clinics, the critical access hospitals, our teaching health centers, our academic health centers, are all good partners with us. We work with the area health education centers closely to talk about that pipeline, to be sure that parents know about loan repayment. National Health Service Corps will do loan repayment for dental hygienists. It's good for parents to know that if their child is looking at this profession or looking in the health careers, where there are opportunities and resources. So you have the opportunity to see what works well and where. And I'm more than happy to answer any questions you might have.